for not putting you guys through fluid balance, acid-base balance. That sort of, yeah. Because no, you know, just the way the fluids move back and forth in the body, and you know, electrolytes move and different things move in and out of the vessels and the cells. I'll leave that to college, and probably depending on what path you take, like if you go into the nursing, that would be in anatomy and physiology too. You know, medicine, it's probably in some sort of pathology that you get. Anyway, you have the fluid balance or water movement and different things. And I watched a couple videos on it yesterday to sort of review. And instead of having you guys watch the videos, I'm just going to sort of summarize it for you, okay? Because I really want to keep it simple, right? Keep it simple, stupid, right? KISS principles. So keep it simple. For where you guys are right now, I think this would be great. And you may already know, so if I say something that's wrong, speak up. Because you've had this probably, hopefully, in chemistry, and that's a lot less time in moons when I had chemistry, okay, and had this. But fluid balance, it is huge in the body. Everything deals with pressure. I mean, we're 70% water, right? 60, 70% water. Depends on what textbook you read. So fluid balance is very big. And so let me go get my mouse before that thing shuts off. Anyhow, we talked about it at the beginning. Pressures. You know, in medicine, you have to savvy pressures. If you don't, then you won't get it. Okay, the full meal deal. Okay, because let's look at just these three here. Okay, and there's more pressures. I could throw off a laundry list, you know, but vessel, intravascular pressure. Okay, what's in the vessel? What fluid? Blood, plasma, the liquid part of the blood, right? You have some water in there. Okay, you have all these other things that are in the blood that floats through the bloodstream. Okay. You have intra meaning inside, intracellular fluid, right? You have interstitial fluid between the cells, and all this relates to pressure. These fluids put a certain amount of pressure on. It's sort of like gas, you know. Yet with oxygen and carbon dioxide, you have different pressures in gas. In those bronchioles, in the alveolus, right, you have different pressures that move that gas back and forth. Now, without saying it, because this is to show you different here, because I'll just read it to you. Osmosis allows molecule solvents to pass through a semi-permeable membrane. Okay, means it allows it to go back and forth. Okay, it has little doors where it allows things to go back and forth. Okay, it's how you say it? Permeable, right? Permeable. Wow. Okay, semi-permeable, new word, pronounced. Okay, but means it allows some things to go in and some things it won't. Okay, next 6 weeks we're going to do cardiac physiology. Those are voltage gated. Okay, so these in the cell are voltage gated. They open due to different voltages within the cell, created by ions and anions, sodium, potassium. Surely you've heard of the sodium potassium pump, right? Mm-hmm. Bio, right? Everybody heard of sodium potassium pump and bio, okay? So that's how muscles contract. So you have all this fluid back and forth. Now, in this vessel here, this is a one without stuff in it, or a solute, right? Big things, and we could list a bunch of them off, you know, that are there. They're just bigger
teachers
things
and
that are in the
students
vessel.
for this interruption.
Okay.
We have a Chevy Malibu, silver in color, license plates KLY 1752. You are parked in the center area between portable 5 and 6. You need to move your car now. It's a Chevy silver Malibu, KLY 1752. You're parked in the center area by portable 5 and 6. You need to move your car at this time. Thank you.
Okay, so this is just water. All these little circles here represent water, okay? And the arrows represent that it moves, right? I mean, it's not stagnant. These things move. They're charged, and they move back and forth. They bounce off different things the same way as oxygen and carbon dioxide. It moves within the container, right? Whatever the container is, it moves back and forth, correct? Okay, so this moves back and forth. Will this semi-permeable, gotta slow down on that one. Semi-permeable, I have to, when in anatomy, when I couldn't say, I mean, I just sit there and repeated it like 1,000 times to try to get it down, you know. But anyway, so that's a new word I'll have to keep repeating so I can say it a little faster. Anyway, it has these gates, and it's just water, so it's going to allow this water to flow back and forth, right? Now this water is still going to move. Like if there's more water here than outside, right? If this water pressure is higher than here, this is still going to move here to balance, right? Because even in this state, we want homeostasis, right? We want to balance. Is that correct? Yeah, that's correct. Okay, so we'll get this free flow of water to balance off. The water moves back and forth, okay? Now, over here, we have something there. Let's say big protein or something, okay? Or that is bigger than this gate. So it's not going to go through, right? If you had a big old fatty trying to get through the door, if he's bigger than the door, he's not going to get through the door, right? He's too big, okay? So it's not going to fit through there. So this is not going to fit. So one reason that this doesn't move back and forth is it's too big, okay? Or it could be a mechanical blockage. This thing's in the way, so this water can't move, right? So this is blocking the gate, so that water molecule that's sort of shooting over towards that gate runs into this big protein. That's what we're going to call it. Who knows what it is, right? But it runs into this big protein, and it can't get through. That's like a little guy like me, and the fatty is blocking the door, right? I can't get through. A lot like the hall people that block the restroom door. Old man's got to pee. I can't get through. You need to let me in the bathroom, right? So, I mean, you got to go in there, but they're blocking the door, so it can't get through, okay? Which is going to affect the pressure of this vessel in some way, or the movement of fluid. Everybody good with that? Mm-hmm. Okay. And the other scenario is that they're charged. Okay. We have cations, which are what charge? Positive, and anions, negative. So let's say salt, sodium chloride, right? And they bind together, and they're going to attract, like the sodium is going to, since it's a positive charge, it's going to attract this oxygen, right? And then this is going to attract maybe the hydrogen, depending on the charge. I may have that backwards. It seems like I have that backwards. But anyway, this is going to attract the water, and it's going to charge up. So now it's charged, so it's not going to go through. So there's just a lot of things in there that balances back and forth. Okay, I mean this is osmosis, and essentially, okay, as far as we want to take it, pretty much. But remember, there's sort of a lot more. But now let's look at the fluid on your handout. Okay, and we've talked a little bit about this. Isotonic, iso meaning equal or neutral. I sort of like the neutral part of it, but equal or neutral, and then tonic solution. You know, not that you guys would know anything about this, but like vodka and tonic or whatever, right? So stay away from that. So it's the same concentration in and out of the cell. So if this was a cell, the cell still has a semi-membrane. So if it's isotonic, then there's going to be an equal flow. It's equal. Fluid's not going to flow either way, right? It's like pressure. When you're airing up a tire, okay, let's say you have a portable thing to air up your tire with, and it's flat, your tire's going flat, and you have 25 pounds of pressure in your portable air tank. When is that portable air tank going to stop giving your tire air?
When the tire gets outside.
Right. When those pressures equalize, no more air comes out. First-hand experience with that. Okay? So it equalizes. There's no movement. Okay? So since we're talking about IV stuff, we're going to talk about isotonic solutions or fluids. So the first and the most popular isotonic solution, and you'll see it non-stop, it's probably 99% of the fluids used, is normal saline, or is here 0.9% saline or normal saline. It's the same thing you put in your eyes if you wear contacts to moisten your eyes, okay? It's salt water. If you taste it, it's salty because it has sodium chloride in it, okay? It has salt in it. So it maintains salt. It's important for fluid balance as well, okay? So it maintains. So the most popular IV fluid is normal saline, NS, right? Normal saline. And that's what they use. If you go down here and you say D5, dextrose in water, D5W, the W means water, okay? It's isotonic until it gets into the vessel. Then it becomes hypertonic because sugar draws out. Sugar is a hypertonic solution, so it will draw fluid out. So you wouldn't give D5W. It used to be the fluid of choice back in the 70s, okay, early 80s, in 70s, 80s, but we'd learned through killing people that we probably shouldn't give them sugar water, right, when they're having a stroke. It kills them. Okay, so or in trauma, it pulls fluid out of the vessel. Right, they're already hypovolemic, so it pulls fluid out of the vessel. It took a while to learn that, okay, through attrition. So we had the fluid called lactated ringers, or LR. Back in my early years, we gave LR, or lactated ringers, to trauma patients, because it stays in the vascular space longer than normal saline does. This fluid will all eventually go out of the vascular space, right? You know, we put it in the vascular space, it will be absorbed later in the tissue or in the cells. So when we want to use an isotonic solution, it's just about on everything. Because we just want to stay neutral, okay? Very rarely do they use any sort of other fluid now to try fluid shifts. We have drugs for that, okay? So it's much safer to give them a drug to cause that. But it's important later in your life, when you start practicing medicine, to understand that if you cause a fluid shift, you could kill somebody. All right? It could be very serious. So we stick really to isotonic solutions. The next one on your handout is hypotonic, or under, and then again for the concentration. Okay, it causes. There's a low amount of solute extracellular, so there's a low amount of the bigger molecules extracellular. Okay, And so it wants to shift the fluid inside, okay? Don't be concerned about that right now. What you want to remember for right now is that a hypotonic solution causes the cell to swell, okay? So the hypotonic solution is going to draw fluid into the cell. What medical circumstance would you use that on?
Dehydrated person or someone that's in like hypovolemia.
Yeah. So dehydration, right? DKA. Remember the polyuria, right? They're like urinating like crazy. Okay, they're losing a lot of fluids and electrolytes and potassium and stuff. So yeah, you might use it there. And there's just a list of the hypotonic solutions. You don't need to, you're not responsible as far as test wise for these solutions. I wouldn't do that for you. It's just general knowledge. That way if you hear it you go, oh yeah, okay, I know what that is. I've heard of that. It's a different solution. Alright. So depleting the circulatory system of fluid, since you push the fluid into the cell, so you have to be careful. Increased intracranial pressure, ICP. When would you have increased intracranial pressure?
When there's freezing in the brain.
Hemorrhagic.
Very good. Hemorrhagic shock. Okay. What?
I said like trauma to the head.
Trauma. Yeah. You could any trauma to the head. Okay. Stroke cause that. Bleeds will cause that. Okay. Excessive burns, because you have fluid shifts and burns. Burn patients, they have a big fluid shift. That's how they go into shock. Some rate it as burn shock. Okay, they have burn shock, so they have a fluid shift. Okay, so anyway, so be sort of familiar with that. And the last one is hypertonic solution, hyper excessive. Okay, and this is just, if hypo swells the cell, what does hypo do? Hyper do? Shrinks it, yeah. So it's going to shrink the cell down when we look at that. Right. So be careful, pulmonary. So down at the bottom, pulmonary edema, fluid overload. Someone with CHF, right? You might do some sort of hypertonic solution. But this word here, vesicant, at the bottom, had to look it up. Thank you, Google. It's a cause of blistering. All right. So check that real quick. Causes blistering. So you have to be careful with these solutions when you order them, when you start administering to them. Like I said, most people, normal saline, right? There's special circumstances that are listed here that would cause you maybe to use a different fluid. But in our case, normal saline, okay? So when you starting IVs now on Steve, normal saline's good. It's always the right answer, okay? I just thought I'd give you this so you have a little bit more knowledge in it, because IVs, I taught my middle son, I think he was 10 when I taught him to start IV. He started one on me, first time, first stick, good IV. Right? I didn't think he was really going to stick me, but man, he didn't have any hesitation. He was like, boom. Right? But very good IV. The reason I did that was to prove to the paramedic class I was teaching at the time that this was a mechanical skill, that you could teach anybody to do it. I mean, I literally could, those little booger eaters that come, it's going to come in a couple weeks again.
Are you serious?
That we have, I could teach them in about 5 minutes to start an IV. Okay, it won't take long on the mechanical skill. The background to it takes a lot longer. Okay, the understanding always takes longer than the mechanical skill. Right? I taught my sons to intubate, 2 of them to intubate. I think they were 12. So it's just a mechanical skill. Again, I did that because I was teaching paramedics And I'll have to tell you the funny story later. It's hilarious. But yeah, I taught them it's just a mechanical skill. So don't get caught up in that part of it. Okay. So let's look at the different pieces and parts right quick. We've already talked about the bevel, right? Let's review it. The bevel in when you start an IV or give an injection or draw blood, whatever the case that you're going to be doing. If you're going to be doing a venipuncture, bevel up. Look for the burrs on the needles, if there's any burrs or any deformity. On the catheter, you would look at this white part here or this part here, the plastic part, to make sure it's intact. Okay, inspect the catheter. They do have expiration dates, so look at the expiration dates on the catheters. If your catheters expire, you don't start near enough IVs wherever you're at, right? Because they last a long time. All right, so the same as needles, when we talked about needles the other day in phlebotomy, they're color-coded. So it's the gauge of wire, and remember that it's international. Everywhere you go, they don't have the same colors. Small, the larger the number, the smaller the needle. So in IV catheters, you have the yellow, which is a 24 gauge, the blue, which is 22, pink, 20, okay, green, 18 gauge. This gray one is a 16 gauge. You guys who gave blood the other day, they started 16 gauge on you. Yeah, because if they start anything less, they have a possibility of those blood cells getting caught up in there and falling apart. Okay, you can't draw blood on anything less than a 20. Okay, it breaks the. There's a medical word for it. I can't remember. Hemolysis. It breaks the cell apart. It lyses the cell apart. Okay, 24s are used on typically infants. I've started 24s on adults that have poor vessels before.
I was about to say, what if someone's veins are tiny?
Yeah, just to get an IV to give medicine, you know, it won't. It's not secure. It's not good for big time drugs. It's just to get maybe a quick and give them, you know, some low level drugs, right?
And what if you need to draw blood but their veins are really crappy?
You have to find it. You have to. They either have to do a central line or they have to do another procedure to get that. You typically can't draw blood out of a 24. Okay, it's just too small. Okay, you can get blood out of a 22 if you want with the syringe. All right, this is for kiddos, children. I've started a gazillion 22s on adults before. Okay, and it's just because they have poor veins. Okay, IV drug abusers, trashes their veins. You'll be lucky to get a 24 in there, a 22. All right. Some medications people take destroy their veins too. I mean, prescription medications, you know, steroids and different things. It makes the vein real fragile. If you remember the anatomy of the vein, right? You have the outer layer's what? The tunica what?
External.
The middle layer?
Media. And then internal.
Right. And then same with when we talk about phlebotomy, you have the lumen, which is the middle, and you're taking that needle and you're pushing it through the layers, tilting it down into the lumen, right? Okay, so the medication sometimes destroys or makes those different layers very fragile, and then the vein will rupture and blow. That's the slang term for it, a blown IV, blown vein. Okay, 20 and 18s are usually an adult size. Okay, a 20 doesn't really hurt that much. An 18, you'll note that. Okay, you'll feel that one. Okay, you'll feel a 20, 16, and 14. It's not on this picture, or for trauma. They're big bore IVs, or where you need a lot of volume going through. Okay, so different catheters for different circumstances. Okay, different veins that you have to that you have to look for. So there's a decision-making process here. That's what I'm talking about. The 10-year-old can't make that decision. Okay, the practitioner has to make the decision on what size vein, what size catheter, where do I start that. Okay, you may start it distal in the hand. Okay, but if the patient needs CT, like say they may have pneumonia and they might go in for a CAT scan on the chest, you need at least a 20 gauge in the antecubital space, 20 or bigger, for the CT. Okay, so there's that decision making. So if you think the patient may have pneumonia, then you start a larger IV, right? So there's decisions. These are your decisions. These are, if you're the nurse or the tech, this is the decision that the doctor's not, they're not going to tell you what size. That's your responsibility to know, okay? So we have the different sizes, the different colors, okay? The larger they go up, the sharper the needle, just the trivia, okay? Medical patients, just try to get a 20 in there so we don't really we don't want to really throw a big IV in there for the pain-wise, okay? Infants, obviously, don't explain it, but little children, when I start IVs on them, I still explain to them. Parents will lie to them, say, oh, it's not going to hurt. I'm like, yeah, it's going to hurt a little bit, okay? So the way that I do it, anyway, so I have a kid I'm about to start 22 on, okay? Or an overreactive adult. Either way, I mean, you have this adult, they're just freaking out over this little needle stick. A lot of the kids will just say, okay, and do it, and then you get an adult that's, you think you're about to, stick a sword in them or something. They're freaking out so much, right? But I tell them here, I say, this is everybody in North Texas has been bit by a fire ant, right? If you haven't been bit by a fire ant, you need to get out more. All right. So anyway, so I tell them this is going to feel like you've been bit by a fire ant. Okay. To give them some sort of reference point to what to expect. Okay. We go up to the 20. I said, what about that bumblebee, that little honeybee? You ever been stung by a honeybee? It's uncomfortable, right?
Yeah.
But it's not like, you're going to die from it unless you're allergic to it. So I'm just saying you're going to feel that a little bit, okay? At 20 gauge, you're going to feel it. 18, wasp. Okay? That wasp. You get stung by a wasp, you're going, wow, that was different. Okay. What about this 16 or 14?
That hurts.
That hurts.
When it's cold?
Oh my God, bro.
Yeah.
And I thought a little needle was gonna come out, in the little outside the
The
belt.
catheter?
But
It's just
I was
the
like,
middle.
oh, it's going in. It's really that big.
Yeah.
he just kept going. I was like, ah.
Yeah, you're going to feel that. Okay? You're going to feel that one. So you need to tell them, say, okay, you're going to feel this. This hold steady. You're going to feel it. And these are very sharp. What I mean by sharp is you can take a new 16 or 14 and you can run it down a piece of paper and it will cut the paper. It won't tear the paper, it will cut the paper. Alright? And 18 and 20 will tear the paper as it goes through. A 14, 16 cuts the paper. You get the difference? So they're really sharp. Now, I said, hey, choose the IV according to, your needs, okay? But keep one thing in mind that you guys don't have any experience with right now is farmers, ranchers, people who work outside all the time, their skin's like leather, right?
Yeah.
Yeah. So you may want to start at 20, but you stick that 20 in there and the thing will go in through the skin. So you may have to start a bigger IV, like an 18, so you can get it in through that thick leather skin. Right? So that's another decision, right? that you might have to make. So keep in mind here, and they all have different reasons why you would start it. Okay? Alright. Let's move on to the catheter. You have the catheter, which is the white part, the needle that's inside the catheter. Okay? The needle doesn't stay inside the body. It will lock back into this safety cover. Okay? You have a wingtip. This is sort of old, but then you have I'll show you when we look at the catheter, you have a thing that you push the catheter on with, a little finger thing. You have to have some finger dexterity, okay? Look at me using that big word, dexterity.
Look how you do it.
Okay, so, and then you have the flash chamber. So when you cannulate the vein, and you get this needle in the vein, the same way with phlebotomy, the blood is going to come out here because of the difference in pressure, okay? And it's going to fill this chamber. That tells you that you are in the vein, okay? So when you see that flash, you push it in, and this is a critical measurement. Write this down, okay? This is a critical measurement that when you stick it in the vein and you get a flash back here in the chamber, okay? You advance that catheter a hair more, a little more, just a little bit more, okay? And then start moving forward the catheter here, or you would push the needle forward just a little bit more, okay? Everybody good with that measurement? A little bit, long wig, that was funny, but anyway, a little more. So you have, then once you get a little bit more, and then you would advance the catheter with the finger, okay? Until this clicks. Now we're not going to do the clicking thing in here, so I don't have to do things I'm not supposed to do with the catheter and get the needle out. We just advance it a little bit. We don't want to click it because it locks in there, okay? We don't want that. So we'll push it. We advance the catheter with practice, but we don't want to lock it, okay? If you lock it, it's not the end of the world, but we don't want to try not to lock the catheter. I'll show you that in just a second, okay? With these fragile veins, like this 22 or so, what I do is just a different technique, and I do it most of the time on all of them. I push it in there, I get a flash, okay? Then I push it in a little bit more, and then I let the entire chamber fill with blood before I start advancing the catheter, okay? Just gives a little bit, let the vessel get a little bit easy with the invasion, okay? Because it's not supposed to be there. That's not natural. So that vessel's like, hey, wait a minute, you know. So it may spasm a little bit, but let that chamber fill. Let the vessel get a little bit comfortable with the new guest, okay? And then advance the catheter. Good. All right. One more thing. The fluid in the setup, right? So you have a solution, doesn't matter what it is, and then you have the setup, okay? And there's different setup with this. This is called spiking the bag, spiking an IV. That's the slang term for it. I'm going to be real embarrassed if I can't say that. My word. Good night. Anyway, this is a little lactated 6% starch. It expired July 2006, so it's good to go, right? So when you take your solution out, check the expiration date. Make sure it's the medication that you want, okay? Sometimes they mark this where it looks like other solutions, all right? So be careful of that. That has happened before, okay? And it's in date, then look at it, make sure there's not any floaties in it, that's good to go, right? So when you take your the line, IV line, right, and then, or the administration set, and you look, it has an expiration date, but probably not going to be anything to worry about. So you look here, and sometimes they may put a lock in there, which has an extension on it. You wouldn't hook this directly to the IV catheter. You would hook this into a lock or something. So if you had to change this out, you wouldn't have to change. You wouldn't have to pull this off of the directly off of the hub of the catheter, the green part in here, right? So you'd have a little loop or pigtail or something. Anyway, there's different size chambers in drip sets. This is a 60 drop drip set. Means that it takes 60 drops to have 1 milliliter. So 1 milliliter equals 60 drops. There's a 10 drop set, which is more common, which would mean what?
10 drops per milliliter.
10 drops per milliliter. That's just for you for right now until you get where you're, actually you might, until you're figuring fluid rates in your medical school or nursing school. That's just trivia. But there's different size chambers, drip chambers, okay? You want to hold that?
Sure.
Hence the spike. Okay? This will go through your thumb. I've had it doing that before, bouncing down the road. Right? Blood under the glove. Like, holy cow. Take a smaller glove and put over it, sort of like a tourniquet, right? Okay. On the IV administration set, you have a wheel part here that you can adjust the flow rate with, okay, and stop the flow rate. So when you go to spike the bag, you want to make sure it's all the way at the bottom, so fluid doesn't run through here. You'll get so much air in your line that you won't be able to clear it. Okay, so here. And then this only has one. Usually two. They usually have multiple IV medication ports. That's what these are. Okay. So if they want to give an IV medication, they can hook it up to there. This one has a threads on it, so you can twist the syringe on here. This one is set up for a needle or a blunt. You know, not the blunt you're thinking of. The square needle will go in there. Okay, so you look at that, and on your IV bag, you have here a medication port where you can push out medicine inside here to create an IV drip of some sort of medication, where you can draw a solution out of it, whatever you want. And then this port right here is where you would spike the bag. Okay, so you take your administration set and very carefully twist that in there, okay, because that spike will go through that plastic. I know firsthand. Then you turn it up and then you squeeze here until it starts filling the chamber, okay, and then once it fills the chamber, you have air in there, right? So you don't want air coming through. So you have to get all that air out. So you just run the fluid out, and it'll start dripping through, and it'll start running through the line. And if you were close enough, you could see all that little air bubbles in there. What will that air could potentially do? An embolism, right? An air embolism. So you don't want that air. You don't have to worry about small amounts of air, but large amounts of air. And this is called priming the line. You want to prime it, get it ready, so you get all that air out. Is it leaking yet?
We'll be in a minute.
Yeah. So see all that air going out of the line? See all those bubbles going out? So you just run it sort of like your syringe, right? When we gave shots. So you just run it out there. Now, you shut it off, and this is set up. This is ready to attach to the patient, okay? So you attach this in, you take off the little cap, and you attach this into the pigtail or the lock, right? And then set your flow rate, whatever rate that you want this IV or this medication to flow. If it's a medication, more than likely they're going to put it on a pump, okay, and pump it through there. In CPR or something, they just let it flow, gravity flow. You can do a medication where you can piggyback it. So if I have have an antibiotic or something that I want to piggyback on this, I can hook that other IV into here and adjust the height of the IVs where that IV medicine will piggyback into here. Okay? There are medications that are not compatible with certain solutions. Okay? Most all medications are compatible with normal saline. Okay? But if you get D5W or something like that, there's a lot of medications that are not compatible with the solutions. Okay? Medicines are not compatible with each other. So you have to sort of look at that. Some medicines will crystallize inside here if you put it in the wrong solution. So be cautious of that. We won't go into all that, but that is a possibility. Okay? So you don't want air, you don't want little crystals in there, right? So that's all for another day. That's your a pharmacology time where you learn compatibility of medications. After you get out of school, you do like I do, and you look at it. If you have any doubt, you look at a chart, compatibility chart, and make sure that they're compatible in the same line. Okay? Sometimes a lot of medications are not compatible. Pretty easy, right?
Yeah.
Okay. Let me change this right quick. We'll watch a very quick video on the procedure. Okay? Starting the IV.
Is it cold? Is it cold?
Okay, so you're at the point where you need to start an IV. If you aren't comfortable yet starting IVs, the most important thing to do is not to panic. If you go into starting an IV with a confident attitude, this process will go a lot smoother. You want to have all of your supplies ready before jumping in. The supplies that you will need include gloves, a beveled needle with catheter, an IV start kit, which typically includes a tegaderm, gauze, a skin prep cleaning agent, tape, and a tourniquet. We have all those things laid out. You may also need a 10 milliliter saline flush, which you'll see in a little bit, and is used to determine whether you are in the correct location in determining your vein patency. You may want to also tear your tape into strips and attach them to the side of the table so be completely prepared to tape your IV in place. To begin, you want to find a suitable vein. There are numerous veins that can be poked, but the most common veins are located on the upper extremity, mainly the antecubital fossa and the dorsum of the hand. Now, there are a lot of tricks out there that seasoned IV veterans use to make veins bulge out, but a few of the more common ones are to ask the patient to clench and unclench their hand into a fist. Do this for approximately 10 seconds. Another trick you can use is to have the patient's hand and arm down by their side so that gravity pulls the blood down into the extremity. Notice he's also clenching and unclenching his fist, doing both tricks at once. Some people prefer to tap a vein, which may reveal a good vein and get them to stick up. Don't spend too long looking for a good site, since patients expect you to know what you are doing, even when you may not be a pro. Now let's begin with an IV start. To begin, you'll need to apply a tourniquet. There's no magic location on where to place the tourniquet, but as a rule of thumb, you want to apply it in half an extremity proximal to the puncture location. So it's half up the extremity proximal to the dorsum of the hand, which is where our IV start will take place. you were to start an IV on the antecubital fossa, which you can see in another one of our videos, you want to tie your tourniquet at the middle of the humerus. Now there are many modifications to the tourniquet tie. You want to make sure you tie it so that it can be released with one hand. We just demonstrated one version of the tie. So if you pull on either one of these ends here, that tourniquet will come loose. You want to tie the tourniquet tight enough to impede any venous blood flow, but not too tight as to amputate their arm. Nice. So now step 1 is complete. You want to cleanse the skin over where you will introduce the needle. This is to prevent any infection once you break the skin surface. Once you've found your vein, you'll most likely want to anchor it.
Who's doing this voluntarily, bro?
Now the vein's clean, we'll anchor it. Veins are mobile and tend to roll around, so anchoring a vein will help you when inserting the needle. To do this, as you just saw, we will grab with our non-dominant hand a few inches distal to the vein. With our thumb, we will apply some skin traction distal to the site, meaning you are dragging the skin away from the site of puncture. This reduces the number of rolled veins and will make you look like a seasoned IV start veteran. Now it's time to grab your needle and a catheter. These come together in your kit. The important thing to remember here is to keep the bevel up. What does that mean? Well, here's a little graphic. You can see that the bevel, referring to this diagonal portion of the needle, is facing up, away from the skin. You want to maintain that all the way through your puncture. With your dominant hand, you want to keep the pointed side down closer to the skin, with the rounded side or bevel facing up to the ceiling. This will allow the needle to pass easily through the skin and into a vein. The next trick is to figure out an angle. You don't want to stick the needle in the arm at a 45-degree angle because we're not digging for gold, we're digging for a vein. This could be very dangerous to the tissues underneath the vein if you have it at a too extreme of an angle. Veins are pretty superficial, so it won't take long before you encounter one. I typically hold the needle at a 15 to 20 degree angle, as you can see here. Make sure you insert the needle in a nice and controlled fashion. Once you hit a vein, there will be a little flash chamber that will fill red. As you can see there, red is filling a flash chamber. This tells you that you have been deep pierced a vein. If you're in the correct location, your next step is to advance the catheter off of the needle with your opposite hand. Remember not to move the needle, you are advancing just the catheter. Ideally, you'd be able to move the catheter all the way up to the skin surface, like so. Sometimes this is more difficult than others. We are simply sliding the tubing off the needle there, and after you advance the catheter all the way up to the skin, you can remove the needle. Some needles, like the one here, are spring-loaded, so they will retract with a simple button push. After we do this, we'll need to stop the blood and stop the bleed. As you can see here, blood is starting to come out of our catheter. You can notice that our practitioner has applied pressure proximal to where the catheter enters the skin, thus impeding flow out through the catheter. Next, practitioner will remove the tourniquet with the one-handed technique, like so. And now the practitioner will check the patency of the vein using 10 milliliters of saline in what's called a saline flush. They will screw the saline flush onto the catheter and then inject it. If the vein is indeed patent, it should slide easily out of the syringe and into the vein. This should not cause the patient any discomfort, and you are merely hydrating them. After the 10 mils are inside the patient, you have ensured the vein is patent, and you now can attach your IV or a cap, whatever apparatus you want to. In this case.
Okay, so they're going to put the lock on it. During the break, come up and see all this. There's a lock up here that I'll show you and everything, and then you can look at the catheters. Okay, so here's a lock. They're attached this in on the hub, and then they have the string here, they're taped down, or the tubing that they will tape down, okay? That way you don't have to remove the IV tubing from the, if you're changing it out, you just remove it from here. So you have a little extension, okay? This they always do this, okay? So there's the pigtail, whatever. One thing that they don't mention here, as you're pushing the fluid in, you're looking here to make sure there's not any swelling or redness, or especially swelling. If you get swelling, you start pushing that in there, and there's a big bubble that forms up on the hand. That means that you've blown the IV, you went through the vein somewhere, and the term is infiltrated. The IV has infiltrated, okay, which means it's not in. Even though you got to return a flash, it's infiltrated because it's through. It got the flash as it went through the vessel, okay, and so it infiltrated. You always watch out for infiltration on IVs. Even when you start running them, you watch out for the infiltration. If you have D5W running, you especially watch out, because that dextrose is, if it gets into the tissue here, it can cause necrosis. What's that mean?
Dead tissue.
Dead tissue. It can cause local tissue necrosis. So you want to watch out. And if you're giving a medication, an IV medication, and the vein is infiltrated, or the fluid is infiltrated, you're just pushing it out into the tissue. It's not going where you want it to, right? So that pretty easy part. It just takes a little bit of practice. So the first thing that you're going to have to practice, let me get an IV catheter, okay, is this part here. All the modern, that's sort of an older IV catheter, but all the modern IV catheters, when you get yours, you'll be able to see it. There's a little plastic tab there, okay, and there's a grip. So you grip the IV catheter with these two fingers. It's a one-handed trick, okay, and then you'll need to practice moving the catheter. See how it's moving the plastic part over the needle?
Mm-hmm.
That's what you have to get, a little finger dexterity. Yeah, there we go. Right. So you get a little finger dexterity going there. It just takes practice to move it back and forth here. It's like walking and chewing gum at the same time. So you do that. This is the first thing you need to practice. Don't push this till it clicks, okay? Because we don't want to. We want to reuse the needles. So you work on that, all right, before you try to cannulate your plastic vein here. This takes just a little bit of time. So you'd stick it in. You'd get the flash. You'd wait. You go that critical depth again a little bit. Push in a little bit. Wait till the chamber completely fills, and then just push it off like this. Okay. What is important as well is that on any vein, if you're trying to stabilize the vein, is to pull it down. So I would be pulling traction down. I'm going to start the IV here, right? So if this was a big old rolly vein like you get on a lot of old people, okay, I would pull this. I would pull it straight, pull traction straight. The technique that people get wrong a lot of times, they're trying to stabilize that vein, and they'll go to the side. They'll pull traction this way, okay? And the vein is round, correct?
Mm-hmm.
Remember, the vein is soft. It's flexible. It bounces a little bit. So when you pull it this way, side to side, you flatten the vein. You don't want to flatten the vein. You want to keep it round. So you pull traction here, upward, and then cannulate the vein. Okay, so then the hand, you'll see, like on this hand, you see a bifurcation right here. When I'll pass it around in a second, but you'll see a bifurcation. That's a good place to start an IV, right in that bifurcation. Okay? One thing that you have to look at when you're selecting a vein is like, if I have this 18 gauge, is that vein long enough to put this catheter in? So is that vein long enough to hold that piece of plastic? So a lot of times I have to measure it. Like, Yeah, that'll hold that. And then I can start it, right? Because veins have different turns and bends, right? So if that's a short vein, and I try to put this long catheter in there, it makes sense, right? It's going to go until it hits the turn. It's not going to go around the turn. All right? So you got to make sure that you have a long enough vein for the catheter that you're using. And the other thing is, sometimes you can see the valves. They look like little knots on the vein. In people's veins, sometimes you can see the valves. Most of the times you can't. But what happens is, if you start advancing this catheter and it stops and it won't advance anymore, more than likely you've hit a valve. Remember, veins have valves to keep from backflow, correct? So more than likely you've hit a valve. The large percentage of the time, if you try to push that catheter through that valve, you're going to blow the vein. It's going to cause the vein to rupture. Okay? What they will do, sometimes it's called floating it in there. So they'll go to the point where it stops. Okay? So it's about halfway in. They'll go through and they'll hook the fluid through there, and they'll push the fluid as they try to advance the catheter. Because when you push the fluid, what does it do to that valve? Opens that valve up, right? And they're trying to, it's called floating it in there. So they're trying to float it in there. Doesn't really work most of the time, but they're trying to float it in there. Okay. More than likely, they're going to have to pull this out, put pressure there, and find another vein that hit a valve. It's not a technique problem. It's just that you hit a door that you didn't see. Okay, and it's what it is. All right. People blow veins all the time for different reasons. Okay. Usually when people start doing IVs, they blow veins because of their technique, because it just takes time to learn how to do it. Then you get other reasons, medication, old vein, fragile vein. You didn't select the right vein and you ran out of space. So there's multiple reasons why they can't start the IVs. Some veins just won't hold the catheter. And you may have already heard this. They touch it with that needle, and it goes, it blows, right? It's just that it's such a fragile vein that it won't hold it. So you get that problem as well. I'll pass around the hand so you can see this bifurcation on the hand. Okay. So let's go back to our oranges for a second. Had to ditch one, had mold all over it. I was going to make some penicillin out of it, but I thought, no, I'll just go to Walmart. Yeah, okay, there you go. At least it's simple to laugh, right? Yeah. So here, you do the same thing. You put the tourniquet on. You do the same thing with the alcohol swab. You start in the middle. You go to the sides, okay, in a circular motion. When we taught UD sticks, and you had the needle, we taught poke it like a balloon, right? Not one of these, right? IV catheters, not so. You want to take it a little bit slower. You're trying to get this tube into another tube. You're trying to get this catheter into that lumen, right? So you got to take it a little slow. You go too fast and you're going to slip to the sides, okay, and nick the vein, and you're going to blow the vein. Okay, you're going to lacerate the vein. So here, I'm going my 15 to 30 degrees, okay. I usually stabilize the catheter with my finger. I get it either sort of on the top or just right to the side. I'll cannulate that. I'll go over. I got my flash of orange juice in this case.
Yeah.
Okay.
I have like 5 different laughs. Oh
You get an A for laugh. Okay. So you go that. I got my flash, and then I just advance the catheter. Now, if I was starting a real IV, I would advance this until it clicks. Okay. But since I don't want to pry the needle out of there, I won't advance it till it clicks. So back to here. before I take the needle out, I'm going to put that pressure on there at the tip, right? If I don't, you're going to get blood coming out there. So I put the pressure there, and then to this part right here. Take that off. What do I have to do to this before I attach it to the IV?
Lock.
Hmm?
The lock.
Yeah, this is the lock. What do I have to do to this?
You have to
Huh?
screw it.
Flush it. Because there's air in there, right? The same as the IV line. So I need to make sure I flush this, and then I just screw that on there, and then I have this, and I'll tape this down over here, and then you have your IV, and you can rehydrate the orange. Okay? So it's pretty easy once you get sort of the technique. Be careful when you slide the catheter back over. Okay? When you DC an IV or discontinue the IV, let me stick this back in here. Okay, so now your patient's going home. So you're going to DC or discontinue the IV. Alright, you'll take your little 4x4 here. You'll put pressure there because it's going to bleed, right? There's a hole in the vein. It's going to bleed. You'll remove this all at once. One fluid motion. Okay? Hold pressure there because it's leaking.
Oh my god, I hate oranges.
It's leaking. So it's leaking some orange juice. So you hold pressure there. Put a little band. That band that I couldn't come up with the name. It's called Co-band. It's that wrap that they wrapped around your arm when you gave blood. It's called Co-band, and it sticks to itself, and it's really good for holding that pressure on there. If you don't hold enough pressure, the patient could develop a hematoma, right? Collection of blood underneath the skin, and you hold it there. What's very important to do is look at the catheter to make sure it's intact. Very important, okay? Because this plastic catheter could have sheared, and there might be a piece of plastic in there, in embolism, right?
How would they treat that? Like if a piece of plastic is in there,
They would. They'd have to find it.
Yeah, and then what?
Yeah, surgically, they'd have to remove it because it could end up in your brain, your heart, your lungs. Could cause any embolism anywhere. Okay, that and the last thing I believe. That's why we don't do this. You'll see this in practice, but you shouldn't. Okay, so let's say that I'm in here, I'm in the vein, I'm in the hand, and I'm trying to fish a little bit, trying to find the vein. One thing that you never do is advance the catheter and then pull the catheter back. You never advance the catheter and pull it back and move it and try to do this again. Because what could happen is that could shear. By pushing the needle back over that catheter, you could shear that plastic or break off a piece of plastic, okay? And then all of a sudden you have a problem. You have a potential embolism, okay? Now, I say you're going to see it because they do it all the time, okay? But it's not a good practice to get involved in. So if you go in there and you can't find it, the correct thing to do, instead of going back and forth with that, is to pull this out. Get another needle. Don't use the same needle. Remember, it dulls it. Okay, even on the same patient. You get another needle, put pressure on the hole that you just put in their skin, okay, and bandage that up, and then find another vein and go at it again, okay. Most facilities allow you like a hospital allows you 2 sticks, and then you have to go get somebody else after 2 sticks. It's a policy thing. In the back of an ambulance, it's just usually a paramedic back there, so you take 3, 4 sticks. If it's critical, you take as many sticks as you have to get an IV, right? Till you get one. And so vein selection's pretty important here. There's a vein here. I mean, hand veins, dorsal veins, AC veins, it depends on what you're doing, okay? And we won't get into all that vein selection today, but it depends on what you're doing, okay? what procedure you're doing. You have a vein that's on the underside here, okay? This is the last resort vein, okay? You can start IVs in the feet. I've seen them at the hospital start in the chest, like IV drug users. A lot of times, that's the only vein that they have. It's in the chest. Obviously, you wouldn't have to put a tourniquet on it, right? But you can start veins in the chest. You wouldn't start IVs on the feet with diabetics. Remember, they had that restriction, that vascular constriction down there. Okay, so you wouldn't start IVs with diabetics in the feet. You start them in the feet. There's big veins down there right around the ankle, the saphenous vein, and big veins on the feet. Okay, you have a really small vein right here that most people can put a 22 in. This right here is a very tender part of the skin. Very tender. If you don't believe me, slap it. Like hard, like you mean it, like you're slapping your mom or something. Right? It hurts. 22 in there, it's going to hurt, okay? But most people have a really straight vein right here, okay? The only time I start it is in someone that's critical, that I can't find any other vein. I'll flip that wrist over. Can you see yours? I got a big old straight one right there, okay? But remember, only when it's a critical time, you need it. Vein's a vein sometimes, right? I call it my Jesus vein. Because if I don't get that IV there, you're going to see Jesus. Okay? You're going to die. That's the only thing. That's the only time that I start that vein. Use that vein. All right. When it's that critical. And I've been in that situation many times where, man, the patient's just crashing and crashing. They don't have any vein. Flip that over. Nice vein there. They don't have any ACs. Either they're too fat or they don't have ACs up here or something. But they have that nice vein there. Okay. But that's all for the future. Okay. So what I want you guys to practice first is with your oranges. Again, doing this. Sometimes the catheters get a little sticky because of the orange juice, right? But I want you to practice this, putting it in there and moving that back and forth here, because the skin of the orange is very similar. Okay, so just do that there, and then practice advancing that catheter. But please try not to go all the way back to click it. All right. Before you stick the orange, however, practice this part here, moving this. It may seem simple, but trust me, I've heard people go, "What? You know, I can't do this. What do I do?" Okay, everybody good? Mm-hmm. Good to go? Obviously, when we get in our groups, you have a needle in your hand. Be careful not to flail it around like a sword. All right. Oh, I'm sorry. One other thing. We'll talk about the tourniquet later in just a second. But you place the tourniquet, you sort of tie a little half knot in there where it comes up underneath, and you tie them there. You want to borrow an arm? I'd come up here. I'd pull it tight. Oh, come up here so I get it on camera. Smile. I'd pull it about 3 or 4 inches above where I was going to start the IV. Okay, I'd pull it tight, and I mean tight. Okay, this is a painful process here for the patient, especially if they have hair on their arms. Okay, so you pull it tight here. See how I have my finger underneath it here, like that?
Yeah.
Very good. Pull it tight, and then loop that underneath there, like so. Then I'd come down. Oh, you got big veins. Okay, so you find your vein, clean it, then cannulate, right? If you're doing a dorsal. So I get that, and just like on the video, it's sort of a half knot. So you boom, slip knot, and it just comes off. Believe it or not, you guys have the biggest problems with the tourniquet, tying the tourniquet. Okay, but that's just the tourniquet, and then you will have an IV start kit usually, and so you go get your catheters. You get everything you need. Get all your supplies that you need. Okay, and then you get your IV start kit, and you sort of lay it out. And there's alcohol prep in there. There's what's called a vena guard. Right? And this just goes over to tape it down. Hospital-wise, they may call it a tegaderm. Okay, it's just a clear bandage over there that goes over the top of the, real thin, goes over the top of the IV to help tape it down. Okay. And there's actually gloves in this one, but there's alcohol in it. Then there's a little 4x4. Technique-wise, what I do, because I don't want blood everywhere on the patient, so once I get my IV in there, I'll slide this little 2x2 or 4x4 underneath. See, this part here is in the skin. I'll slide that underneath there in case I just don't put enough distal pressure or proximal pressure on this point here. Okay, and it bleeds out a little bit, then it bleeds into the 2x2. Okay, and then I don't have to wipe the patient's skin off, get the blood off. Good? Okay. So, or if I'm removing it, I would use this and hold direct pressure. All right, good deal.